Are there any questions from the audience? Please come up to a microphone, introduce yourself with your name.
I'm Sean Costin from Albuquerque. I'm just wondering if...
Just a second, let's have everybody sit down.
It's a administrative question, really.
Yeah.
Is the test center going to be open Saturday morning?
Yes.
Okay.
So there were a bunch of questions asking, you know, how much time does it take to learn a device, or how often should one do it to get proficient at it, and what is the level of proficiency? And the answer to all these questions is basically, this is why we are doing what we're doing. We are actually trying to build a proficiency validated accreditation for you to be knowledgeable and know how to use devices safely. Nobody has that. So the answer to all these questions is we don't know, but we have now, we are developing with your help and your participation in the validation process, the curriculum and the certification process to make somebody safe, a safe user of surgical energy. So that answers those questions. But if there are more questions in the audience today, please come up and ask. There's one question that goes probably to Malcolm or Dan. Which vessels are greater than 5 millimeter? And so are there particular vessels in mind when you do surgery where you say, boy, I shouldn't use a harmonic or ultrasonic device? Can you name a few? And then why don't you just clip or staple them? Who wants to take that question? Tom?
Sure. I think that the larger blood vessels that I encounter as a general surgeon would be the splenic artery, which is likely larger than 5 millimeters. And so I actually don't use either energy-based device on that. I think if you look at the evidence, a linear GIA stapler is probably the gold standard for laparoscopic large vessel sealing. And then which other vessels are more than 5 millimeters? I think the IMA is probably right around 4 or 5, so the inferior mesenteric artery. And the other larger vessel that I divide regularly would be the ileocolic on a right hemicolectomy. But again, I don't think that's over 5. That's probably 4 or 5 millimeters.
So in my field, which is hepatobiliary, it would be the gastroduodenal, and I've used a vessel sealing device on those. But I think most surgeons would add the safety of a clip or a tie. But in laparoscopic Whipple procedures, some authors just use a vessel sealing device to divide that vessel, and that's probably in the 5 to 7 millimeter range, depending on the patient. On one more, go ahead.
The adrenal vein, I think, is one that is in the 5 millimeter range, and personally, I've been clipping that.
I think if it's got a specific name, you got to think twice about just using it.
Excellent answer. Okay, so
well, I do donor nephrectomy, and we use a ligature or bipolar sealer on the left side on all the branches. So it includes the adrenal and gonadal, which can be quite large. Although I think we didn't discuss, about when we're sealing larger vessels, about the use of multiple seals. And with the bipolar, of course, or at least with the device that we use, you can seal it, take a look at your seal, you can add another seal. It doesn't have a built-in blade, so you can look at it and make sure that and of course, when you're dealing with any vascular dissection, you want to have the vessel dissected out. You're not just going across it, just like you would dissect it out in order, you could put a clip on it, but I think in those circumstances, even if it has a name, you may be, it may be one role for that. And it's nice not to have the clips in that area if you're going to be stapling. I think there is some benefit to that.
There's also one brand of clips that was used in donor nephrectomy where people had post-operative major bleeding with, so clips are not necessarily foolproof.
So the beauty of this texting and tweeting system is that there are some comments, actually. And one comment was that every operating room has fire extinguishers, and they're hanging on the right right inside the OR door under the phone. Now, I'm going to say, I'm going to go back and look, because I asked around a few people and they didn't know where these things are, or if they even had one. So apparently there must be a rule out there that obviously makes sense. But still, ask yourself, do you know where they are? Because when I ask myself or ask my colleagues, most of the time they say, I don't know where they are. So it's important, I guess, to know. There are a bunch of questions about studies, and these go to Tom. How do we make sure that, or how do we see if a study is not sponsored or biased by industry? So I figure it's probably almost impossible to answer that question, because every device is industry-backed somewhat. And how important, the other question was that was related to that. Where on the scale of importance does cost of electrosurgical devices fall? Maybe you can answer or comment on those two questions.
So the first issue was how do you fund objective studies without industry support? And I think that there are some studies that on the disclosures have no industry support. The one I would point out, and I used it a couple times, was Lamperton's article, and it really looked at a broad range of instruments. But I do think, being somebody who publishes once or twice a year, it's critical that industry gives us some of the infrastructure, whether it be the thermal cameras or whether it be the burst pressure devices, to make these studies happen. And then how do you reduce conflict of interest? I think it's just like with any other thing, is, you know, whether there's actually money flowing or whether they're just borrowing instruments. I think that's a slippery slope. And that's something you as a surgical reader need to be looking at when you read these evidence-based articles. And I think that's how I would handle that question.
Thank you. I have a question for Charlotte. What does the healthcare quality team require to ensure a suspected generator is acceptable to be put back into service after an adverse event?
Well, one of the things that happens when they're looking at those devices, each device has a manufacturer's suggested maintenance schedule and suggested PMs that have to be done on the device. So you depend on your biomedical engineers to take them through the steps to show that they're working properly. If you have any questions, we also use those questions by looking into, for example, the ECRI databases to say, has this device been suspect in other things as well? So those are the things that we use. Good testing, good function, and looking into the literature to be able to say a device can go back into service.
Thank you. I want to thank all the speakers for staying on time. That was perfect. I would thank you all for coming today. Remind you to try to take the exam, visit the Learning Center, and feel free to talk to us and ask questions on a personal level. Thank you again for coming.